and Health Select Committee. This is being broadcast live and recorded for publication. To Agenda 1, appointing of Chairman and Vice Chairman. To note, the appointment at Annual Council on the 14th of May 2026 of Councillor Joseph Rich as Chairman and of Councillor Kev Dale as Vice Chairman of the Adult Social Care and Health Select Committee for 2026 to 2027 of this year. Agenda 2, membership. To note, the membership for 2026 to 2027 as Councillors Bestwick, Councillor Dale, Councillor Darrington, Councillor Girling, Councillor Gould, Councillor Goland, Councillor Lee, Councillor McCark, Councillor Pepper, Councillor Rich and Councillor Wheatcroft. Agenda 3, minutes. To ask committee to approve for the minutes at the last meeting. When the hands up. Okay, that's noted. Thank you. And to ask the committee clerk if there's any absence.
Yes, Chair, we've an apology from Councillor John O'Lee, and that's for other county council business, and the substitute today is Councillor On.
Thank you. Thank you very much. Yeah.
Also, apologies from Councillor Barry and Sir, who's unwell.
Thank you. Agenda 5, declaration of interest. If any councillor or officer has an interest in any matter of the agenda, you should declare it now. Please raise your hand now if you have any interest to declare. If you have any interest to declare, you should state it, what type of interest it is, and give it a brief detail. Oh, okay. So just a quick reminder, this is a scrutiny meeting. We are looking to evidence to focus on outcomes and hold services to account in the public interest. This is plenty of opportunities for political debates elsewhere, so let's keep the political out of the room and to keep meetings structural and fair, and I would like to set a few ground rules. Keep it clear. Please make sure your questions brief and to the point so our officers and guests can respond effectively. One topic at a time. Please avoid combining multiple questions into one. Thank you. Agenda number 6. Housing and supporting accommodation update. To ask Guy, the Executive Director for Adult Social Care, to introduce the report. Thank you.
Thank you, Chair, and morning everybody. I'm Guy van der Kloor, Executive Director for Adult Social Care and Health in the Council. So the purpose of this report is to provide an update in relation to the Council's duties and ongoing activity regarding housing and supported accommodation. It will provide you with an update in relation to the use of supported living accommodation and the aligned impact on the Council's use of residential care services, which has been a key programme of work for us, and to highlight the role of the Council in commissioning supported housing and the challenges encountered and solutions developed and proposed. I'm now going to hand you over to Katie Ball, our Service Director, and she's joined today with Megan, one of our officers. Thank you.
Thank you. Morning, everyone. So I'm really pleased to be bringing this today. Just to remind people of some context, as we all know, housing and where we live is really important to having a good life. It's one of the building blocks of good health and well-being. We created a corporate housing strategy in 2024, September 24, and we have a whole council working group looking at housing for people. In terms of general needs housing, the primary responsibility for that sits with districts and boroughs as part of the Housing Act 2004. But from an adult social care perspective, we work under the Care Act 2014, considering particularly supported accommodation for people that draw on care and support, where that is one of the best options to support their needs. And that means that we need to look at housing that is appropriate and adapted, where support can be on site. That might be in a flat or a house, but you have your own front door and the support coming into you. The support can be a whole range of things. So we talk about supported living, which is mainly for people under the age of 65. often with a learning disability and or autism, or mental health as a reason for the support. And we also have extra care, is the phrase that we use, which is particularly for people over the age of 55, who might need a little bit more support, which might be personal care, it might be independence, which is about supporting you to not need to go into residential care before you're ready for that. So it's a really important part in a suite of things that we can make sure is available in terms of care and support. So from an adult social care perspective, we did a needs analysis to have a look at where people want to live and need to live. And there are some really lovely quotes from people about how important it is to have your own front door and that independence and what it means for people. We've had an over-reliance on residential care in the county for some years. And what we've been doing, and what I would say about that is, we don't want residential care is great when it's right for you, but nobody wants to be in residential care when you don't need to be there. That's not the right place. So this supported accommodation is about the right support at the right time for people, and being in a place where you can maximise your own independence and live your gloriously ordinary life in the way that you want to live. So we did a lot of work as part of the corporate housing strategy and for adult social care, looking at a needs analysis of how many people are in residential care that actually want and could be in supported accommodation or general needs housing, and how do we support them? How many people do we think might be coming in from other community settings or from home, or people coming up through our children's system where supported accommodation is going to be right for that person? So we looked at that whole needs analysis. We've also just done, we did that first, and we've just done a similar one in terms of extra care, so 8 part of ageing well. So in terms of our supported accommodation, we did that needs analysis, and then we worked really hard with lots of engagement with external developers, care providers, to talk about our aims and what was important to people. And we did quite a lot of co-production work about what it feels like to live in your own home, what's important, how should they look and feel. And through that, we've done a raft of procurement activity, and we've built what we call a pipeline, which is a list of places that are being developed for people. And over the last year, in terms of supported living, so people under the age of 65, we over 100 people have moved into supported living, which is fantastic because we didn't have that available before. A third of those have stepped out of residential care and into supported accommodation, which means they now have their own front door, they have much more independence, and some of those people have a goal to eventually, with support, move back into general needs housing, which is absolutely brilliant. So in terms of progress and pace, we're really proud of that. We've got over 100 supported living homes still on our pipeline and in development, which means they are going to be coming online this year, next year, or the year after. And we've got a range of procurement activity that is trying to stimulate more. Our needs analysis tells us that we need over 300 more supported living homes over the next 5 years. But what we also want to do, is part of our future focus, is to try to increase the flow of people that are in supported accommodation being able to eventually move back into general needs housing. And so that relationship with our districts and boroughs is really important in that element. In terms of the broader picture of supported living, we have over 1,000 people, 1,031 was the March figure, people living in supported living, compared to 555 people under the age of 65 living in residential care. And we've still got some people that hopefully will be able to move back out of residential care. In terms of extra care, so for people over the age of 65 with personalised support in the home, it's often a really great place to live for people rather than going into residential care if you don't need it. It often becomes the permanent home for somebody for 50% of the people that live in our extra care homes. So it's a really important part of what we're able to offer. We've got, I think our latest figure, Helen, is it's 205 people living in extra care, and we've just been doing our needs analysis, and is it over 200 more that we need in terms of at least of extra care homes. So that's really important work for us as well, and we are going to try to bring the same market engagement and pace to extra care that we've been bringing to supported living over the last 2 years. Also, what's important to talk about in terms of what we're doing is we have part of our Better Care Fund, which is money that comes into the council and goes out to districts and boroughs, is our Disabled Facilities Grant. That is money that is used to adapt people's homes, which is really important, again, enabling people to stay in their own homes and live independently. We have integrated community equipment and loan service, which is really important, which does a whole range of things, but that's where we can put things like grab rails, etc. So actual equipment into people's houses, and again, enable people to be independent, that little bit of help in your own home. We've also attracted capital funding, and so we've put bids in nationally to NHS England. And over the last few years, we were really successful in pulling in 3.5 million, where we developed specialist supported living to support people with a mental health need, which has been really successful. And actually what we saw in that is, again, people being able to move out of hospital and into supported living, which was really, really positive. We do have links in terms of planning for some of our children and young people that are coming up through the children's system that are going to need accommodation into adulthood as well, and that is part of our needs analysis. And then thinking more broadly, and part of the work of that corporate housing group is to think about what we want to represent for people up into the really big planning across Nottinghamshire for housing. And so thinking about how do we age well? How do we plan housing and communities to support people to live in groups and age well together? Also think about the types of houses that are being built. Are they houses that can be adapted over time so that somebody can stay in one house and the house adapts to their needs? And those are the kinds of things that we want to champion more up into housing plans, spatial strategies, etc. across Nottinghamshire. So that voice up into EMCA, our East Midlands Combined County Authority, and that spatial strategy is really important. And that joint work about supported housing and accommodation with our districts is really important as well. So us being part of influencing those plans and inputting into needs analysis is part of what we do. So I hope that this is a useful overview. One of the things that I will note is for the people that have moved from residential care into supported accommodation, we have some fantastic stories of difference of how that has felt for those people's lives. Increased independence, which meets what we should be doing under the Care Act as well, but also generally costs us less for people to be in supported accommodation than residential care. So it makes sense and is really important in terms of best value use of public money, but also meeting people's outcomes. Thank you.
Thank you. So I'm going to move this to recommendations in detail of the report. I need a seconder.
I'll second that.
Thank you. I am now going to open the floor for a debate. Councillor Girling.
Thank you. I've got two questions to ask, but I'll ask one at a time as instructed. What I'm interested in is the relationship between mental health and housing, and how that influences or impacts on the person's ability to get accommodation, to get a house, when they're suffering from mental health, because it's not always, oh, we know about that person, something can happen and then they get mental health from it. And because we rely heavily on the district councils and borough councils for that, I can only really go off my experience with Newark and Sherwood District Council. So I'd be interested to know overall, you know, are there any areas, any boroughs and districts within the county that aren't really performing as well as they should do? And I know you don't really want to say because you don't want to upset them, but we need to know, I think, because we can then try and influence those districts and boroughs. And you know, do they really take it seriously that when you get somebody who's got mental health issues because of the fact that where they're living at the moment, they're getting antisocial behaviour against them from ex-partner? It's a case, so I'm not going to mention names, but ex-husbands and family against them. She moved in with a mother, sofa surfing, and now the mother's being attacked. Yeah, and trying to get her accommodation elsewhere it seems nigh on impossible, because it doesn't seem to me that it's being taken seriously enough that that's the sort of thing that this person's putting up with, and then having even worse mental health issues from it. So if that's happening with me, I'm sure it's happening with others, and I'd be interested in what the spread of that is around the county.
Thank you. It's a big question. So I've got a range of things in the answer. I think in terms of support that people need is across quite a range. So the example that I gave earlier, we can see some really complex high-end needs where we've had some really powerful stories of difference where people have been in hospital for some time due to their mental health for a very long time actually, and sometimes through really important times of your life, like moving from childhood into adulthood, where typically you'd be learning independent skills and living with a group of friends or with a bit of support from your family, you kind of learn how to live independently. And actually we've had people that have been in hospital during that time, for example. So to be able to come back out of hospital and to live and be independent is challenging. So us needing some really personalised, bespoke accommodation for people that have been in hospital for a long time has been really important. And some of the life-changing differences that having the right accommodation that's been built and created for them to be able to come out has been exceptionally important, and has given those life chances back to people to be able to have independence, with people coming in supporting you with your mental health on a very, very regular basis, and sometimes to the level where we have got technology that is monitoring you all of the time. It doesn't mean that it's filming you. It's monitoring if you need something, and a level of safeguarding risk, which has been incredibly successful. So an example that I would give, which I have used in a different context before, is somebody that came out of hospital, being able to live independently. And previously, staff would have needed to go in the night to check that that person is safe because of their mental health. But actually the technology is checking if that person is getting up and moving, etc. And so that person hasn't got that less dignified situation of someone coming in the bedroom at night, but the technology can alert if somebody needs to come. So that whole way of kitting out accommodation to support people to be independent, to gradually have that support from social workers over time, and that might be 6 months, it might be several years, but to build back to a much greater level of independence and improved mental health and well-being. We've got some amazing stories of difference. So that's an example at the very specialist end. In terms of, I think you were asking me more about that access to general needs housing. I think it's really difficult, isn't it? What we see is there's more demand for general needs housing than there is supply. And that's really hard for all of the districts and boroughs. So there are we understand that there are waiting lists, and there has to be a prioritisation. We know that we do have quite a number of people. We've been looking at who is in supported accommodation that is almost ready already, or has got an ambition to move back to general needs housing and that level of independence. So we've been looking at groups, and we understand those numbers, and there are quite a number. So having access to general needs housing would be really important in their lives, really important for us as a council in terms of meeting our duties. But it's difficult. It's hard because there isn't enough. So it remains a future focus, and we are working really closely with districts and boroughs who are also understanding how important this is, but face that daily issue of there's quite a big waiting list. So that's really hard. And I think the other bit that you alluded to was domestic abuse and support around people. We have got an appendix that the appendix is about homelessness and temporary accommodation, but there is a little bit of that is also called the Sanctuary Scheme, that is about supporting people that have experienced domestic abuse. That is contracted through our public health team. So that is a support service that is there. But domestic abuse continues to be a really difficult issue. There's way too much. It impacts people's lives. It impacts children. What we would like to not happen is for people to have to move far away, children move schools, be moved away from all of your friends. We would like to be able to remove a perpetrator away from the situation. But there is a joined up strategy across the county around domestic abuse, which also links in with our safeguarding channels too.
It does. And can I just on that? Sorry, apologies. And it's Emma Shand. I'll introduce myself properly in due course. If it helps to have a conversation outside of this regarding that constituent's actual situation, just in terms of the support that we offer through safeguarding, through what, the organisations we work with, and also the local social work team, very happy to do that. Yeah, it sounds like a very difficult situation, and unfortunately is not an uncommon one. So thank you.
Thanks, Jim. Well done for avoiding the fact of which districts and boroughs aren't performing over the other ones. I'll let you off with that. You can tell me separately if you like. My second question, if I may, Chairman, is when I was a Cabinet Member for Economic Development and Asset Management, one of the things I implemented was when it's our land, because that's when we can have the most influence, that we negotiate with the developers that we have supported accommodation built within that estate, if you like, or within those builds. Is that still the case? Is that still happening? Because I hope it is, because that's a way of us getting the accommodation that we need to be able to support those people.
Thank you. We are hugely grateful for everybody that supports that direction, obviously. So yes, that is something that is being discussed. It's part of why having a corporate housing group is really important, because we are having exactly those conversations. So on our corporate housing group, we talk about, as a council, when we're looking at our assets, either to sell and be developed, or an asset that could be transformed into something else. Could it meet some of the needs that we've got for our needs analysis? So could it be a property that could be converted to supported living or extra care, firstly? Secondly, if it's going to be housing, can we start to include some of that support either for a small children's home or supported accommodation for adults as part of that development? I think there's more work to do on that, but it is a conversation that's continuing, and we're really pleased that it is a conversation. But we would like that to be coming to fruition.
Councillor Darrington.
Lovely, thank you, Chair. Disabled Facilities Grant. Can I assume that this is means tested?
apologies. We can, Head of Service for Occupational Therapy, Maria Ballantyne here, maybe best placed to answer that question.
Good morning. Yes, disabled facilities grants are means tested.
Super, lovely. And from knocking on the front door with reference to the grant and then the process of applying being deemed satisfactory, what is that time process from knocking on the door to fruition to delivery?
It very much depends on the complexity of the adaptation. That's the first thing to say. This disabled facilities grants also is an umbrella, if you like, over our own service in terms of occupational therapy, who will make recommendations for the work which a person requires. From that point, the recommendations are passed across to the local and borough councils, and it's their process that they own through to sending out surveyors, etc., right through to planning adaptations, recruiting and sending out for contractors, and then obviously the length of time that that would take. Ultimately, obviously, if we're looking at a ground floor adaptation, the length would be longer because obviously we've got to consider how best to meet the needs of the individual. If it's a less complex disabled facilities grant, then obviously, such as a straight stairlift, for example, that could be off the shelf, if you like, then that work will be done more quickly. But ultimately, the time that it takes for our recommendations is obviously quite quick, if you like. It's just when the process passes across to our colleagues in housing, then obviously the waiting time sits with them.
Thank you.
Councillor Bestwick. Thank you.
Thank you, Chair. First of all, can I say thank you for your report. It was very illuminating, and some of the numbers involved, I think, show us the scale of the problem that we all face. I mean, it's not just officers, it's everybody here and the whole community. Because I'm a bit of a numbers nerd, just looking at some of the numbers, if we took the past 12 months of adults who've been moved into supported living, I think that still leaves 555. And at that current rate, it would take us 16 years to be able to say that we've completely solved the problem. Even though I know we're all working really hard to do it, from speaking to Guy previously. And this might be a question for Councillor Answer, so please feel free not to answer it. But is there any evidence from the Cabinet that they're prepared to invest further in trying to solve this problem? I know we've been successful in getting that 3.5 million from the NHS, but unless I'm mistaken, I can't see anything in here where council funds are being accelerated in order to accelerate this programme, which ultimately will save the council some money. So I don't know if there's anything you can tell us on that.
Thank you. Two bits to that. Firstly, the numbers. So yes, we have got 555 people under the age of 65 that are in residential care. Actually, residential care is right for some of those people, not all of them. So there are still some people that would be working towards moving into supported accommodation. But our needs analysis of over 300 includes people that we see coming in over the next few years as well. Just wanted to be clear on those numbers. The second bit about investing into this, I think one of the we've had a lot of support every time we've talked about supported housing. Something that we want to start having a look at is a feasibility analysis of investing money. So starting to look at an outline business case for doing that. And I think what we probably did need to do first was the market engagement work with the external developers to see the pace of what we could get going quickly. And now we can have a look at complementing that and a business case to then bring forward and be discussed.
Thank you.
Councillor Golan.
Thank you. I was interested in the relationship with districts, and in particular the districts that don't have their own housing. So presumably there you're working with the registered providers and the Homes England and people like that. How does that relationship work? And how does it work when you have housing distributed all over the community? Because obviously some people that would be what they want, but for others it might make life harder, I imagine, if there's no local support networks that you can build up when there's more concentrated housing.
Thank you. That's exactly why doing a supported housing needs analysis together with districts and boroughs is really important, and Megan in my team, Helen, etc., have been involved in that, and we have really strong relationships with the districts and boroughs. So creating that needs analysis together is important. Making sure the voice of adult social care is really important into that, so that people understand where do I want to live, what's important to me. Making sure that people are living in places that they can walk to, local amenities, everything you've just said. Be part of a community, have the opportunity to socialise with other people, get to the shops, particularly in things like extra care. Being able to still do your own shopping is important for all of us. So we don't want to make things like that keep all of us independent harder than they need to be. So absolutely that co-design with people happens. We've got some lovely stories of people that have visited the site where they're going to live while it's being developed every single week, and watching it go up and been so proud to move in. So absolutely thinking in that way, thinking about independence has been really important. Doing that needs analysis together. The work that we've done so far, because we needed to really get the pace going on this, we've done a lot of engagement with external private developers to come and build, and then we've worked with the local districts, etc., and local care providers. So we've had some care providers that have wanted to take on accommodation, and so do both, have accommodation and provide the care. But we've also got the scenario where we've got care providers, and it's a landlord that we work with, and the care goes in. So we've created procurement routes to be able to do both, which has been important.
I was really focusing on that relationship with the providers, because I know at the district level, where they have no housing in my district, it always seems this is a bit of a sort of, black box. There's nothing, it's out of our control. There's nothing we can do, nothing we can say. They just do what they want. In that circumstance, how much influence and control even do you have?
Well, we were in a position where we were working with developers to show what we need and where we need it, in a kind of more of a relationship. So then developers would understand that there is a need and build, and then we would contract with the care and make sure that care was personalised, and then bring that to the people that live there. What we are doing now, and some of it's in the report, is to show that we're trying to structure things in a number of ways to be more flexible. So where we have got care providers that own properties, they can do both. Where we've got care providers that don't, we're still fully making sure that we are working with both the care providers and people that will draw on the care and support to co-design some of that support so it works in the right way. And then we are procuring that formally. So we're doing both. Is that, am I answering your question?
I suspect it's just really difficult to engage, I imagine, but I think that's what you're saying, probably.
I'll just add a little bit to it. I think the approach that we've taken has been really proactive, and one that I think you're absolutely right. Relationships need to be built, and that's what you've been doing through the commissioning function. Because the alternative is that people will come and build and do things that actually aren't meeting the need of the people that you want. So actually, we try to discourage that really. Now, obviously, that is very difficult because of planning permission, and people can get planning quite often for things that are not necessarily are things that we would want to come. Quite often people ask us for more residential homes, for example, whereas actually we've got a wash of residential homes, and what ends up happening then is people will place from elsewhere into those homes to fill them, and then they become a responsibility for us, because actually our safeguarding responsibilities are for everybody who lives in the county. So having that proactive approach, having those relationships building, which does take time, which does take energy, is a better way of doing it, so that actually people who are snooping around looking to see whether they can use a piece of land to build something means they've already seen that there's something already going on there. And so actually that's a much better approach, really.
And just to give you a little bit more as well, Megan will talk about, we've been developing a registered provider framework. So all of this has been to respond to, we need so much more, and we need to do it at pace but do it right, which is why we've done so much in terms of building relationships, a lot of co-production, but we are trying through a number of ways to accelerate the pace as much as possible. But Megan's just going to add a little bit to that as well.
Hi there. Yeah, so as Katie and Guy have said, a lot of our focus has been around that building of relationships and the proactive approach with housing providers. We are in the process of designing a housing provider or registered provider framework in which we can have a contractual relationship with housing providers. And as part of that, there's been a lot of market engagement with existing providers within Nottinghamshire and those that fall outside of the county as well, to look at where we can build on other relationships. We know that there's interest from housing providers to work with us in this area, and there's interest in the framework that we're designing as well. So there's been some really positive steps around that. It does take time, and when we speak with providers, there's lots that they learn as they go through working on each development as well. So with the work we've done with private developers, each time we're working on a new opportunity, we've seen opportunities to build and improve on what we're doing there, so that the properties and the accommodation that we're working on better meets the needs of people as well. So there's a huge amount of work happening around the engagement and the relationship building there, so that we can try and design a procurement process that meets our needs as well as the needs of housing providers.
Councillor Gerlin.
Yeah, thank you, Chairman. Given Councillor Beswick's question and the response, which we sort of anticipated, to be fair, we'd like to add a recommendation to the recommendations, if we may. Can you just pass that down there? And I've written it out so you can see it. But part 3 of the recommendation, that the committee requests Cabinet to explore opportunities to accelerate the delivery of supported living and extra care accommodation through an investor-save approach, including consideration of whether savings arising from the continued occupation of County Hall could be redirected towards increasing supported accommodation capacity and reducing reliance on residential care. All we're doing is asking that they look into it. Sorry. Okay, we've got plenty then.
Let's go for a general meeting and to put this recording to stop for a moment.
Just adjourn the meeting.
So again,
You're just going to adjourn the meeting.
I'm just going to adjourn the meeting. We had this amendment with Noel, and we want to take it to amendment to Noel. Yeah, I forgot to say that.
If we want to start the broadcast again, please, first of all. It started. Thank you. Can you just, I think Councillor Rich is passing to me to make comment, if that's all right, Councillor Gerling. Councillor Rich and the group have looked at the proposed amendment, and they in turn would like to propose an alteration to that amendment. If I could read that out, and then it's for you to decide whether you accept that alteration, and then we'll take it from there. So just to read out, so you all have a copy of it. So basically, the proposed alteration would read that the committee requests Cabinet to explore opportunities to accelerate delivery of supported living and extra care accommodation through an invest to save approach towards increasing supported accommodation capacity and reducing reliance on residential care. So it removes the reference to including consideration of that bit, but keeping the basic tenet of the proposed amendment. Would you be accept? So that's an alteration to your amendment. Would you be prepared to accept that?
Just confirm we're broadcasting again, are we?
We are.
Okay, yeah. Thank you for that amendment, which I don't really object to, and we will accept it. However, I just think it's important to understand if the plans had gone ahead, we'd have moving out of County Hall completely by July this year, and that's £1.7 million savings, which could have gone to something like this. So that's why we put it in, because it's important people understand the implications behind the decision to stay in County Hall. Yeah, it's costing at least £1.7 million a year to run, and the occupancy is really low there. So that's why we put it in. But I do accept your amendment, because ultimately we want to accelerate this. Yeah, and it will cost money, and then we gave you an example of where that money could come from. Thank you, Chairman.
Thank you. Just to say then, and thanks for your response, Councillor Gerling. So on the basis of that, then this third amendment that's become an alteration is now a recommendation. Okay, thank you. So it's a question as to whether you wish to continue with the debate or if you wish to move to the.
Yeah, thanks, Chairman. No, I don't know if there's any more questions actually. So, but I'm happy that if you want to move to the vote, move to the vote.
I'll answer a question then before we move on. So what's the opportunity does LGR potentially provide in delivering suitable housing to meet the needs of all residents?
I'll answer that, and I'll ask whether you want to bring in Katie. I mean, I think it goes back to some of the earlier conversations about the districts and the relationships between housing and social care. So I think one of the advantages of local government reorganisation and becoming a unitary is that it actually brings those things closer together. So it enables us to have housing and social care working much more closely together. So we see that as a plus. And we hopefully will be taking the advantage of, when we do become a unitary, to be able to have integrated teams across housing and social care.
Go on.
On that, which I understand what you said, but it won't increase the amount of houses we got, because they're all got undersupply. So all it means is all the undersupply comes to one place or two places, depending on which way LGR goes. So the amount of accommodation required and the amount of houses we've got does not change because of LGR. It just doesn't. Mathematically, it can't. What it does mean, as far as I understand it, is we have more control over it, and we can coordinate with better because we've got all the strings, but we've still got the amount of deficit in terms of accommodation.
I mean, you're absolutely right, but actually the influence of having a one unitary housing plan across the piece that actually enables people to downsize from large houses where they have some real alternative to for older people, particularly because quite often we don't have enough housing for older people to downsize from, which then frees up housing for families to move into some of those bigger houses, to then think about the investment that we need to put into supported living, but also then to have policies within housing to give enable people to move from supported living into general needs housing. So it's about creating flow, because actually we want people to continually to be in the right place that they want to live, in a community that they want to live. And that's some of the interest that we have in terms of the pace in which you can go with supported living, because actually these are 500 people that we've talked about that actually are all at different stages of where they are in their independent skills. And so actually some of that is about working with them in order to get to that place in the right area for them as well, particularly where they have families.
Thank you. To ask Martin to read any out of areas for further consideration that have arisen from the discussion.
I think we've got everything. I think the major thing was the thing we've had the alteration on, so there's nothing further to add.
To note that the recommendations have been moved and seconds take to the vote. No, wait, well, hang on. Yeah, that's right. Yeah, to note the recommendations have been moved to second and take the note on a show of hands. Thank you. Right then, agenda 7, update on delivery and performance of the occupational therapy service. I'm going to ask Guy, Executive Director of Adult Social Care, to introduce the report. Thank you.
Thank you, Chair. We're very pleased to be able to give you an update on the delivery and performance of the occupational therapy service. We recently moved to a county-wide service, which will be explained to you, but obviously therapy is a key part of the offer that we do for people in many situations, but is a really important part of people's ability to stay independent. So I'll hand you over to both Emma Shandler, Service Director, and to Maria Valentine, who is the Head of Occupational Therapy.
Hey. Thank you very much. So we're delighted to come to speak to you today about occupational therapy. We did come 6 months ago to explain about the changes we'd made in terms of a county-wide occupational therapy service as part of an organisational redesign we undertook in our operational services last summer. We spoke a bit about the opportunity in terms of occupational therapy, the value of occupational therapy, and then we're asked to come back 6 months later to say, how's it going? How are we doing? And actually, how can we kind of evidence that improved performance around OT and how we make the best use of our occupational therapists, but also the value that adds in terms of improving people's independence and supporting them to live good lives. So that's what the report details today. I'll start with the quote about what is occupational therapy for those of you who may not have come across it before. So occupational therapy helps you live your best life at home, at work, and everywhere else. It's about being able to do the things you want and must do. That could mean helping you overcome challenges such as learning at school, going to work, playing sport, or simply doing the dishes. Everything is focused on your well-being and your ability to participate in activities. So it's really about how do we support people to live good lives, doing the things that they need to do and they enjoy doing. So a really focused and therapeutic approach to positive outcomes for people. And the occupational therapists that we work with in adults, well, in social care, actually, I should say, actually work with children as well as with adults, and are also a key element of our Preparing for Adulthood service, who are the sort of transition from children's to adult services. So really thinking about independent living skills and how we support young people and children and adults to overcome some of those challenges that they're facing. Our OTs work in different areas of practice. They work with older adults, they work with people who are recovering from an accident or an illness, particularly around hospital discharge. They work with people who are experiencing mental health challenges, and also work with people who may have a learning disability or autism. So the really wide range of skills that the occupational therapists use, and the people they work with and the lives that they touch. As I said, they work with people of all ages, from children to older adults, and we've recently also reviewed our principal occupational therapy post, which is our therapy lead for the council, and the post now covers children and adult services, which is a real step forward for us in Nottinghamshire to think about that whole life journey and the whole family approach to occupational therapy. Occupational therapy is a key element of our prevention, early intervention and proactive approach to supporting people to live independently, and for us to intervene earlier in people's lives rather than letting things get to crisis level. So anything we can do to support people to live as independently as possible, to learn skills and regain skills, helps them to live good lives and be independent, and also helps us to manage our resources more effectively so that our money can go further in terms of people that need it for support. We've talked a bit about occupational therapy in terms of the Disabled Facilities Grant as well. So that also sort of in terms of some short-term interventions for OT, but then also longer-term interventions and recommendations about what can be actually huge structural projects for people's homes in order for them to live well at home. So in terms of the service, our occupational therapists work with that person, that young person. They also work with their family and their carer if they've got an unpaid carer. They also work with care providers as well to support them in terms of the best placed way to support people to live well. A key example of that could be supporting somebody in terms of how to move and position them, particularly if they've got mobility issues or needing particular equipment, or if someone's cared for in bed. So how do we make sure that they're cared for well and then they're moved safely and effectively? In terms of our service, and in terms of our performance measures and how we're measuring our success, there are key measures really around our kind of quantitative measures. So how many people do we see? How quickly do we see them? And sort of then also thinking about the benefits realisation in terms of resource allocation. So actually, by supporting someone to be more independent, we can then think about actually that saves the council some money and the taxpayer some money in that respect. But also our qualitative ones, which are really important in terms of actually how's a person's voice heard, and what outcome, what difference has that made to their lives in terms of the sorts of things that they want to achieve that they're now able to do. And that could be something very small, such as washing the dishes, or could be something about returning to work, and it could be overcoming a life-changing injury, for example. So there's, in terms of point 11, there's a list of different interventions that give some examples of occupational therapy, the sorts of things that the OTs work with in terms of some of that's very kind of domestic and personal care related, to some much, as you said, particularly thinking about in terms of housing and also some of the technological and digital solutions that we use as well. So it's a really wide-ranging use in terms of the skill set of our occupational therapists. The service is divided into two. We have OTs who work in our maximising independence service, and they're short-term work about promoting people's independence, supporting them to learn new skills or to regain skills. So a lot of those occupational therapists work with people who are coming out of hospital, and in terms of supporting them to get home and then to live their lives well at home, and to adjust in some situations or to regain skills that they may have lost if they've been ill or in hospital for a period of time. The children's OT service particularly look around what support the children need to live their lives at home, but also linking into school as well, and thinking about equipment and things like that they might need, but also approaches of how to do things, strategies and ways of managing daily life, which make life easier for those children, those young people, but also for their parents, their families and their carers. Some of the longer term of intervention is undertaken by our community occupational therapy service, which is now under one umbrella, which it wasn't before, and is led by Maria. And that's some of the longer term work. So people with longer term health needs, disabilities, and also for those who perhaps need a slower pace of support in terms of reablement. We also have occupational therapists who are more specialist and are placed within certain teams. So I spoke a bit about preparing for adulthood. So that's an occupational therapist who works with young people and their families. We have an occupational therapist who works with our Transforming Lives team, which is supporting people out of long stay mental health, learning disability and autism institutions. And often, and that work's quite nuanced in terms of really thinking about environmental needs for those people, but also some of their sensory needs as well, and how we support those people well, particularly when they've been in a hospital environment for what can be a significant amount of time. We also have occupational therapists within our adult deaf and visual impairment service, so working with people who have a visual impairment, who may be deaf or have a dual hearing and sight impairment as well. All key and very quite specialist roles in terms of supporting people and responding to their needs and their outcomes. The report takes you a bit about how many we've got, just so in terms of numbers, and we were keen to increase as and when we can do, because we really can really see the value of occupational therapy, working alongside our social workers and our kind of care providers as well. So in terms of the redesign, which we took place, well, it was this time last year, in fact, and then for occupational therapy, really from sort of September, because we did some recruitment and things over the summer, creating some new posts. The aims really were better outcomes for people and carers, that we would better support people in their own homes and their communities, that we would be able to provide a better consistency of experience and approach for people and carers across the county by establishing a county-wide approach to that, and also a single leadership structure in terms of under one head of service, and to use and to increase the use of cost-effective, life-affirming community resources and digital solutions, so the tech-enabled care, to promote people's independence and their quality of life. The report talks a bit more about the specifics around some of the posts that we have in place in terms of our workforce in order to make that happen. And then I'll take you through the improvements, which we start from paragraph 24. So we've got some data. It helps if you've got it in colour. I don't know if yours are. I've got a colour in grey, one in grayscale and one in colour. But in terms of just giving a sense of our in terms of number of assessments undertaken, which we've managed to increase significantly over the last year, and also then in terms of waiting times, which were last June at the highest they've been, and then gradually our trajectory has been to reduce that waiting time down in terms of how long people have waited to be assessed by an occupational therapist, seeing a slight increase in March, which isn't unexpected when we think about winter pressures and people coming out of hospital late end of winter and early spring. So it just gives a bit of a sense about our kind of average waiting time as was in March, and Maria will have the up-to-date information for today, was 20 days waiting to see an occupational therapist. Now, if someone was urgently needing to see an occupational therapist on that day or the next day, then we have a system where we make sure that happens and people's referrals are prioritised accordingly. But that was the average waiting time. The report also talks a bit about how we can, through your occupational therapy, to really think about people's living a sustainable life, but also in terms of the service and also in terms of our offer from adult social care. So we know that early interventions through occupational therapy with people and actually with their communities really help people to live better for longer at home. And we've also instigated an approach in terms of where people do have to wait. Actually, how do we support them to wait well? So how do we link them in with other organisations, other information, and the information that they need in order to be able perhaps to make some of those links themselves, or with some support. For example, if there's part of their need for occupational therapy is around social isolation, we can start thinking about who else is around that we could start to bring in earlier in the conversation rather than needing a formal assessment straight away. We do very close joint working between our occupational therapists and social workers. They sit in the same offices, they're serving the same population and working with the same families. And although we've moved the service to a county-wide occupational service under a particular head of service, what we encourage very much is actually our OTs are a key part of our neighbourhood teams, working in their localities, knowing their people, knowing their communities, and working closely with social workers, but also with the community voluntary sector and also with health partners as well, forming a wider kind of integrated neighbourhood team. There's been some particular work around also with public health, so thinking about the sorts of population that we serve in Nottinghamshire, particularly thinking about those areas where we've got particular pockets of deprivation, poverty, and higher incidences of comorbidities, so having lots of multiple health conditions, particularly where life expectancy is low or healthy life expectancy is lower than we would like it to be, because as we know, there's quite a disparity across the county in terms of that data, unfortunately, in terms of people's experience and their health. So in terms of really thinking about what occupational therapy can add to that, and some key bits about public health also, about how we support people who are plus sized in terms of the equipment they might need, the adaptations they might need at home, and also for those who are we would say petite, but perhaps where an example of that would be where We may have a person who perhaps has had an eating disorder and then needs very kind of specialist equipment in order to make sure that they're looked after well at home and then start their steps into rehabilitation and getting on with their lives. So a key part of occupational therapy for us, as well as the physical side of things, is also the mental health side of that as well. So in terms of, I suppose, some other examples is around and innovations that we're now starting to bring in now that we've sort of built the service, is really thinking about that integrated neighbourhood working, thinking about how can we get our occupational therapists out of our offices, out into local communities. So that could be using, sort of supporting in terms of using health buildings such as GP practices. It also could be thinking about Inspire and our library provision and how would we use those buildings and those spaces, of which we've got many as a county council, in order to actually get out to see where people are and fit in with how their lives work really as well. We've sort of spoken a bit about the Disabled Facilities Grant already, but again, that's in terms of by having a consistent approach across the county for us, although we're working with different district and borough councils, as we've alluded to already, that consistent approach from the council has helped us to really sort of help us gather data, but also have a voice of occupational therapy more strongly with our district and borough council colleagues as well, and then linking very much into the work around housing strategy and actually what's our future thinking and needs about what we need for our population. And in key, I think, element about that just also is that work along, which is we're building on more around our children and families provision and how we're working with our colleagues in children and families services and special educational needs and disability in terms of how can we really think about the value of occupational therapy there and how can we use our resources more effectively across children and adults in order to get occupational therapists to where they need to be. So I'll stop talking at that point. Welcome any questions, comments, reflections. Thank you for your time.
Okay. I'm going to move the recommendations as detailed in the report. I'm seeking for a seconder.
I'll second that.
Thank you. I'm now going to open the floor for a debate. Thank you. Councillor Girling.
Thank you, Chairman. I'm not really a charts and graph person, so I might be completely out of it here. But if you look at paragraph 26, I'm assuming that May 26 isn't there because the report was done before you got the stats. But I'm amazed that you managed to get October 26, November 26 and December 26 stats in. You're working really well there to get the numbers down. What can you explain? Is it just an error or have I misreading it? Because
David to Maria as head of OT. He's also got the live dashboard open as we speak in terms
okay, well, according to my report, in December 26, you did 2, and you can't tell what it is because it's 2.
Yes.
Yeah. So I don't know what that means, because how can you know that you've done 2 assessments in that time? We ain't got there yet.
Quite right. Quite a good observation. I would say that's an error, obviously. We are doing some work on our dashboards, which obviously pulls all of our information together. So absolutely right. But obviously going back to the data in terms of March, again, you're correct in that obviously when the report was written, we were looking at the information for March. So, but yes, we have and we are continuing to make sure, obviously, that our occupational therapists are moved up in the assessment process. So obviously what we are looking to do is make sure that our occupational therapists in the place-based team, so not at the front door with our maximising independent service, but in the districts, are obviously making sure that we are collating all of the correct information, albeit for October and November, and obviously making sure that we're doing our early intervention as quickly as possible.
Thanks, Maria. And that's a textbook mistake, isn't it? So I can only apologise about that. We think we've had a bit of a shifting of notes, certainly not, and I didn't clock it. So thank you for reading the report so well, and the eye to detail is all I can say. But apologies for that, and we can supply the data as we go through the year, and we might come back another time and tell you how the summer went in 2026 for OT.
Councillor Bestwood.
Thank you, Chair. Mine relates to graphs as well, I'm afraid.
You're into them though, aren't you?
So, thank you for your report again. really good information, and again, it shows that I think the scale of some of the issues that we have as a county. And just looking at your number of people waiting graph, I can see that obviously there's a big spike over the summer, and then we've got that number back to total people waiting back to sort of where it was in April 25, and I can see that there's been a lot more interventions, so I can see how that's happened. I suppose I've got two questions really. One, are you seeing overall that there's an increase in the need for occupational therapy just generally? So you're expecting the numbers to go up? You're nodding, so I'm guessing you are. And then as a council, do you feel that as that need grows, are we going to need to increase the number of OTs and CCOs in the future? Thank you.
Thank you so much for the question. And I am nodding. I'm going to hand to Maria because this is a question that I have for Maria most weeks is, can I have more staff? But in terms of, I suppose, thinking about our population and the demographic and particularly an ageing population, absolutely we expect that we would need more of more occupational therapists. Also, I think in terms of pressures in terms of the NHS, waiting times for the NHS, we also see that in terms of people wait for longer, unfortunately, may become more unwell and then need more sort of therapeutic support once they've been through had an operation or they've had the support they need from our health colleagues. But in terms of sort of, I suppose, some of the other elements about that from a practice perspective and from a much more, I'm a social worker, so not an occupational therapist by profession, I'll hand over to Maria about some of those demographic pressures and staffing sort of investments that we'd like to think about.
Thank you for your question. So in terms of the first question you asked, in terms of are we seeing more of a demand for occupational therapy, what I would say, there is always a demand for occupational therapy. It just depends on where we pitch our intervention. What we tend to see in social care is the opportunity where people come to us and then we identify that they need occupational therapy intervention. What we are trying to do, as Emma was saying, is we're trying now, we have our waiting lists under huge control, much better control, so obviously we know and we can plan. We're actually doing a piece of work where we're moving our occupational therapists closer to the front door, just to say actually those people who are coming in and potentially that we don't know about, who are calling in for information, advice and guidance, we're actually going to put some resource to the front door so actually we can have conversations so that we can make sure actually that we are planning for their future. So for example, if someone contacts us and says, actually, I've just been diagnosed with dementia, I'm not 100% sure what it is that my future will look like, or we have a carer calling in for that information, we'll have an occupational therapist based at the front door to say, okay, let's organise and have a conversation. Let's talk about the diagnosis. Let's talk about the prognosis. Let's talk about how we can maintain you in your own home for as long as possible. So one of the things that we will be looking to do is working with people who are newly diagnosed with dementia, for example, working with the carer. What the carers don't ordinarily understand, quite rightly so, is that the person is still there, but the personality is very different. So actually what we can say is, please don't, if perfect conversation is, as dementia progresses, actually the person with the diagnosis will say, I want to go home, I want to see my mum, I want to see my dad. Obviously they would have potentially passed away, so what we're saying to the carer is actually that's normal. Don't say actually they're dead, they've passed away, etc., which obviously is a really poor conversation to have. Just say yes, they're coming back. So actually that would be able to support any kind of challenge in the home. So what we're looking to do is educate people a little bit more, a little bit further up in the process, if you like. And obviously with our children's work, what we're looking to do is become earlier involved so that we can look at promoting independence. So working with parents as well, so that they can say, actually, as a parent, all of us teach our children to get washed, to get dressed, to eat, to go out to the community, etc. What we'll be doing as occupational therapy is working closer so that the demand what we hope to be the demand on social care will be less in the future, because obviously we're instilling those independent skills with children earlier, and obviously supporting parents to let go a little bit.
Come back, Chair. Yeah, so thank you. I think what I was getting at was, is there an increase in demand? Right, I know there's a demand. So is there an increased demand, which I think Emma answered? And when I mentioned, have you got enough staff? I think your answer was you're changing working practices to make it more efficient. Is that a fair summary?
It is, and apologies for that. So
Sorry?
yes, occupational therapy will always be needed. Yes, we're making the service more efficient. We could do so much more with additional staff. However, we're just obviously touching the top of the iceberg, really. But absolutely, I don't know, Guy, if you want to come in.
Yeah, I mean, what I would say is I think Nottinghamshire is quite lucky actually, because actually majority of the occupational therapy sits within the council, and that's not everywhere. So a lot of people just get it through health, where we have heavily invested in making sure that our social work and therapy service is one that is of equal value. I think the second thing to say is we particularly want more people to go through occupational therapy than necessarily just a social work service, because actually a lot of occupational therapy work comes from a rehabilitation perspective, and so therefore enables people to get back to a point at which they can independently live and continue with their lives without intervention from us. And the more we can do that, the better it is, really. So I think we're in a window now between now and LGR. I'll use that timeline, because actually what will happen when LGR happens is there'll be a whole load of district staff and community work that will come into the unitaries. I think that's the point, and when we'll have to look at where are the balance of occupational therapy, social work, which will deal with the statutory work, versus what can we do in the community to support people to stay and live and reduce delay and want statutory work as long as possible, really. So I think we're in a sort of window between now and then, really.
Councillor Gowland.
Thanks. I also had a question about figure paragraph 26, because the data for April 26 is a lot lower than any other month, which would imply something amazing happened. Now, I'm not sure if lower is good or bad in this context, because obviously it's less visits, which might be good in a way, because it might mean it's all done before or something like that. But I think it's not. I think it's the same question. You talk about efficiency, and I wonder what that means in terms of visits and who visits, and is all the occupational therapy, and maybe it's a good thing, but is it all being provided by professional OTs, or some of it being provided by other staff now, which is maybe a good thing?
So no, I'll make a start, and I'm going to hand over to Maria. But no, thank you, and I think it's really helpful to have the kind of conversation, and actually really appreciate the time that you've taken to really go through the data and ask those questions, because it's really important. So I'll hand to Maria, but I suppose one sort of element about the April visits was, and it is an impact for us because we have a workforce that are predominantly women who have children or families, or may have caring responsibilities. So thinking a little bit about when the school holidays happen also does impact in terms of our assessment activity, although we mitigate that as much as we can do. So I'll hand to Easter Holes. Yeah, so I'm going to hand to Maria, though, particularly around who understands the data in more detail.
Okay, thank you so much. Just to clarify that the report was written mid-April, so the full detail wasn't available. Yes. No, well, thank you for the question. So actually, in April of 2026, there were 1,046 occupational therapy assessments undertaken, so just a little bit lower, but we think that's again probably because of the Easter holidays, but it's slightly lower. However, again for May 2026 we did 1,009, and obviously it peaks almost around when school time, when children are in school, we have a lot more requests for occupational therapy. Just going back to your question around who actually undertakes the assessment process, we do have qualified occupational therapists And then we have multi-skilled community care officers as well who go out. In general, the workforce is quite stable. We're in a really positive position at the moment where we have people wanting to come to us, but we don't have the post for them. So we're looking obviously to make sure that all of our community care officers, our multi-skilled community care officers, are very experienced, most of whom have been with us for a really long time. So obviously we're making sure that we can be as efficient as possible with everyone who's going out to undertake those assessments.
I suppose just to note that as well, we're really fortunate to have to retain our occupational therapists really well. We've got a really loyal workforce, and often when we're talking about adult social care particularly, we talk about shortages of staff, whether it's care workers on the ground, social workers. For us in Nottinghamshire, and I think this is some testament really to the investment that Guy mentioned around into occupational therapy, is we have a stable occupational therapy workforce with very few vacancies, and we recruit well. So it's a real positive in terms of story for Notts really, in terms and the offer that we have for our residents. So yeah, but thanks for the question.
I mean, we were just talking, it's so important to invest to save, and obviously it's not just to save, it's to make people's lives better, but it is really great news. Thank you.
Thank you.
Councillor Girling.
Thank you, Chairman. In your, Maria, this is to you really, in your response to Councillor Bestwick's question, you said something that sort of made my ears prick up a little bit in terms of it depends where you pitch your interventions. So I'm a little bit concerned about that because as a layman, so I don't really know how it works, but you can manipulate your figures by where you pitch it then. So I would hope that where you pitch that intervention is set for you by the cabinet member, and then that's a pitch that you follow it at. Has that changed? Is it still the same as it's always been, or where are we with that? Because that's a really important point. If we're saying actually they don't need to have intervention now, the bar's up here instead of down there, it will impact on all the figures, won't it?
I can come in then. So no, thank you. It's a really important point. I think, and I'll allow Maria obviously to speak for herself in a moment, but actually what we've done is actually think about how can we actually bring our occupational therapy further upstream. So where we've been in a position before we had the kind of service redesign, it was perhaps a more reactive, less proactive approach. So in terms of seeing people later, meaning they're perhaps more in crisis and their needs were higher. So in terms of bringing that intervention earlier in people's kind of, for want of a better word, journeys with the council, that we can intervene earlier in terms of providing better advice and guidance, but also that kind of enablement, rehabilitation support earlier on, as so that their illness or whatever hasn't progressed quite so far. But I'll allow Maria to come in and give some examples of that. But was my interpretation, rather than us thinking about what looks best on a graph, or what looks good for statistics. Actually, what's the best point in terms of clinically to intervene in someone's life, and when they're ready for us, but also what's maximum impact really for them as well.
Thank you for the question. So just to clarify, in terms of pitching our intervention, what I mean is everybody who contacts the organisation are entitled to an assessment of their needs. So occupational therapy will see everyone who has an assessment in, and obviously, as Emma and I've said, we're moving our resource a little bit further upstream so that obviously we can identify and meet with those people earlier on. What I mean by pitching, once we do our conversation with people, it very much depends what their needs are. So we will either offer information, advice and guidance, we will offer alternative ways of doing an activity, or it could be that we have to consider equipment or adaptation. So that very much depends on the needs of the individual that's actually coming into the organisation. So it's probably bad wording on my account, but just to clarify and confirm that we do see everyone. And obviously as therapists, what we want to try and do is make sure that we support people to maintain their wellbeing and independence. Everyone is very different. We're all shades of grey, black, white, etc., etc. So what we're trying to do is listen to that person. Actually, what is it that they need? It might be that they need grief counselling, for example, and actually as therapists we can actually sit down and ask those pertinent questions. So we very much are led by the people who come to us to ask for our service. Hope that answers the question.
Thanks for the answer, because that's reassured me a lot. You did pitch it wrong because I thought, well, hang on a minute, but no, that answer's really reassured me that you didn't mean pitching the way I understood it.
No,
so thank you. Thanks, Chairman.
Any more questions? No? Oh, I'll ask a question then. So this one is more related to Gowland's question kind of thing. So I'm looking at section page 29, B2, usually B and 2. So the proposal to place an advanced occupational therapy practitioner directly into the customer service centre represents a major proactive shift in how we can manage or what semantic barriers need to be removed to ensure that this becomes a permanent structured part of the intake process rather than just temporary projects. Thank you.
I think the intention is to make that permanent. We've been testing out the importance of how much you can do very early on at the front door. So it's not the only area for occupational therapy. We've also now started to consider benefit officers, thinking about them at the front door as well. So actually we've given much more universal offer at that at the customer service centre, which hopefully then gets dealt with once, and then people can continue to get on with their lives rather than have to come in or wait and then come to talk about their story again. So it's a trajectory that we want to keep building up, really.
To ask Martin to read out any areas for further consideration that have arisen from this discussion.
I think from the discussion we had, I think it would be really helpful if we could have an updated chart from paragraph 26, so we could send around to members of the committee, like when it comes to a point in the next, like say, few weeks, when it's a nice, when you've got all the data we can supply, so members can have that good overall view.
Yeah, we can do that. I think what's happened is the lines have moved in the printing across, and so actually the dates are now not aligned to where the lines are, so that I can see how they should have moved over each one. So yeah, we'll get that printed for you.
Thank you. Right, to note, the recommendation has been moved and second, and take to vote on a show of hands. Thank you. 8, to prevent an adult social care. To ask the Executive Director to Adult Social Care to introduce the report.
Thank you, Chair. And we've heard some good things today already about where prevention has been important in housing, but also in occupational therapy. And this is a further iteration of that in terms of wider prevention in adult social care, and where we're going and what we want to do with this. So I'll hand over to Katie Ball, our Sales Director, and her colleagues to take you through the report.
Thank you. I think I would want to start by saying we hear so many positive stories of difference, of how lives have been changed and improved every week. Looking at Emma, we hear so many lovely things in terms of adult social care, particularly being involved and helping people. We also hear difficult stories of people getting to places or crisis that could have been avoided, and I think we all know people and have some of those stories of things that have happened. Prevention is so important. We are so passionate about it, and I think everybody in this room would agree. I want to remind us of the context nationally over the last 15 plus years, in terms of the austerity that impacted. We've been through a pandemic, a cost of living crisis, etc. And actually what we've seen happen, particularly in public services, is a shift of the money and the spend to firefighting at the acute end. So we saw, which is the opposite to what everybody would want to do. We would all want to put more resource into prevention, early intervention, early help, whatever language we want to use. So we saw a national deep dive into the NHS, by Lord Darcy, and that's where the NHS 10-year plan came from, which has got the three major strands of trying to shift back from hospital to community, illness to prevention, analogue to digital. And we now have on that report didn't comment on adult social care intentionally, because it was a big enough brief. We now have Baroness Louise Casey, who is nationally looking at adult social care, which is really good. We want that spotlight on adult social care. And Louise Casey has brought out some very early messages nationally about the creaking adult social care system and the pressure on it, and the concerns around that. And she's brought out some early messages around things like we all nationally need to be prioritising and looking at themes like dementia, which is a growing issue. So we are awaiting for Louise to progress that work further, but it's really useful to remind ourselves of that context. I am really pleased to say that in our council, we've really focused heavily on prevention. We started off with, we were doing lots of work, but we formalised some of that work under the Care Act, which gives us the language of prevent, reduce and delay the need for higher levels of support, or to help people to step back down to more independence. We were already doing quite a lot of work. What we did in 2024, so 2 years ago, around about now, is we produced a needs analysis. We call it a JSNA, Joint Strategic Needs Analysis, about adult social care prevention specifically. And that was a really interesting piece of work, told us a lot, had the voice of people into it. It's where it strengthens that lens for us, understanding the sheer amount of people that are struggling with things like social isolation. And we all know that you do better when you've got a network of people around you and friends and people to help. And if you haven't got that, it's really hard. And we also see stories of people that might now be struggling to do their garden, struggling to tidy the house, feel embarrassed, stop inviting people around, and that's where deterioration can happen. So in that broader context, we've worked really hard to respond to our JSNA chapter. We produced a prevention framework for adult social care, which was looking through what we already do, identifying where we'd already got other pieces of work, like our housing strategy that was increasing that focus on prevention, our technology-enabled care strategy, giving people technology that can help them stay independent for longer. And also we've got a carers, unpaid carers strategy, which is incredibly important for us. So in our prevention framework, we looked at where do we want to turn the dial up further, and what do we want to add in? And that's how we started to pull together as a group and look at what are the next steps for us. So we did that work. I'm really pleased to say that in our CQC assessment in December, CQC really strong, and we feel proud of. I say this with the caveat of course, there's a lot more to do, and we're very focused on that. But CQC talked about Nottinghamshire has a strong and well-developed prevention offer with clear strategies and a wide range of services. Most people experienced improved outcomes in their well-being and independence as a result of the local authority's prevention offer. We have a range of services, facilities and resources and other measures to promote independence and prevent, delay or reduce the need for care and support throughout the authority, and it does cite some of the specific areas. So we were really pleased to have that recognised. CQC also recognised that our adult social care prevention offer and the broader work that we've been doing as a whole council to look at what's the earlier prevention support look like and how do we make it a priority, and that has been formed under our Thriving Communities programme, that the two things fit together, and actually the Thriving Communities programme is to wrap around us. So I'm going to give you a few examples of what we've been doing. Prevention is a spectrum. we can think about that really early support, the building blocks of good health. So having good housing, making sure there are jobs for people, making sure there are places to walk to, people around you, good leisure offer, all of those things in the good building blocks. At the acute end, it's good crisis support when, for example, there might be a carer that is really exhausted and struggling, and needs some support around their own health and well-being, and there's a risk of a family breakdown. We have teams that can go in and support, and technology that can support and really help carers with their own health and well-being, and let them have a break, and be able to go and do something that is good for their own health and well-being. So we've got that high-end support, and we've talked about examples today through the two reports that we've had at that higher edge of crisis and how we support people back to a healthier, happier place. Where we've really focused, so we're looking at the whole, but where we've really focused our adult social care prevention framework is in what I would call the proactive prevention, that middle bit. People that are just coming into adult social care or are already drawing on care and support, and what are the things that we can do now to have more of an immediate or within the next couple of years impact for people, to support them to stay independent, to maintain their good mental health and well-being, or to have a plan to start stepping back down to more independence. So that's where we've really focused, which has been important. So we do a whole range of things that are outlined in the report. That starts with the adult social care front door, making sure we've got great information and advice, and that we tailor that and we take the time on the phone to really understand in that strengths-based way what people need right now. And sometimes what people might think, it might be something different. Like Maria just said, it might be that somebody is struggling with one thing, but actually it's grief. They've just lost their partner. They're really struggling. So really taking that holistic think family approach, making sure that we're giving good information and advice. Thinking about reablement. So we've got equipment and things, people that are just on the edge of needing something. We are very fast at putting grab rails or trolleys. Somebody might have just stopped shopping. They've got vascular dementia. They've been having some falls. They are struggling to do their shopping. It's a really key trigger for losing your independence. Actually, what we can do, working together with health teams and our own teams, is get some balance work in there, have a walker so that you can keep going to the shops with a bag on it, so you can actually put your shopping in it. All of those early things, and then that person doesn't necessarily need us for a while. And things like technology, I know that's been well rehearsed here, but we have so much fantastic technology enabled care and bits of kit that can help people with medication and reminders and monitoring if somebody needs more support, or if somebody's fallen over, all of that early alert stuff. Then we have a range, if people are then coming in and drawing on care and support, we have a range of things that we can do in our offer. We try to stay really strengths-based. That means focusing on what is strong for people, not just what's wrong. Who have you got around you? How can we strengthen some of that? People that are quite socially isolated, how do we help you to have contact with other people, not just sit in your home having a meal delivered, but how can you get out? How can we connect you with others and think differently? And obviously occupational therapists are really key in that as well. And then we have a whole range of support. There are some really nice examples in the report that show the impact of what we do. Things like we've had people that might have been in a day centre that didn't leave that building that are now part of a day network. So groups of people that meet together in Mansfield, for example, in a place that they've chosen that they like to go to, and they're working on a range of goals together. And it's really sociable, it's really strengths-based, it's really led by those people that meet. We have digital inclusion work so that people can connect and talk to other people online and search for things that are useful for them. We have a frailty hub. We don't necessarily love the word frailty, but it's a nationally used word. So when people are beginning to struggle, that might be dementia, it might be falls, it might be a whole range of things. We've got a great way of getting multi-agency teams around that person and that family, and often the carer, to put in place a whole range of things so that people feel confident. And we've had people tell us, particularly with things like technology-enabled care, I thought I needed to go into a care home. I now can't believe I was considering that. I feel great. I feel much more confident, and thank you for these things. I want to keep living my life in my own home. So we do a whole range of things in terms of our offer. Nationally, I would always want to say there hasn't been a big investment into building a strong enough evidence base around adult social care prevention, which doesn't mean that things aren't working. It means there's a lot that hasn't been evaluated in the same way that the children's context and the pure health context has. So I've been part of a national working group. There was a national toolkit that was launched just over a year ago, supporting local authorities with how to start building your evidence better. And one of the things that we've done, we do in our teams work to look at the impact for people, and we're building our own local evidence base of what has improved outcomes and what hasn't. And we have actually had some match funded money from NHS England nationally to have a local authority research practitioner that we're sharing between adult social care and public health. So that person at the moment is helping us to skill up in terms of evaluation, also look for research bids and bring money in to help us to build our local evidence base, which is really important. So we're doing loads of stuff. We work outwardly with our external providers. We've got a group that meet around strengths-based practice and sharing good things. We've got a digital group of providers that meet and share what they're doing with digital solutions that are working for people too. So that's how we're meeting our Care Act duties and showing some of the impact that we're having and that external validation. But then as a whole council, we've been looking at our Thriving Communities programme. So that is about thinking, what can we be doing at an even earlier stage? So that's thinking about the voluntary and community sector grants being really important. We want a vibrant voluntary and community sector. We want to have great relationships with our voluntary and community sector. They know their communities really well, and we want to be able to pick up the phone and say, can we do some thinking together about this in this area? We've got a bit of a gap. So that's really important. Under the Thriving Communities programme, also thinking about into our neighbourhood model, where we've got people that we might call them social prescribers, we might call them community connectors, our health family have contracts for different teams as well. But looking at all of those people that could help connect people to attend a local singing class or to build your confidence to start going out. Those roles are really important. So our Thriving Communities programme, looking at how those roles work is really important for us. But also that whole wider range of things like wellbeing and weight management, vaccinations, etc., making sure that the right people are getting all of those things. How we are specifically linking between the adult social care prevention framework and Thriving Communities is we are looking at people that are just getting a tiny little bit of adult social care support and looking at whether we could do some work through our voluntary and community sector grants to look at, do those people really need to be in adult social care, or could we support some of those people in a different way? So starting to look from that angle, and also to bolster the great work that we do with people that draw on care and support that want to get into work or volunteering. We've got our own brilliant service in Brook Farm. We also work with iWorks, who are absolutely fantastic and support people with a learning disability and or autism into work. But we're looking at what could that link through Thriving Communities and our voluntary and community sector be, where we can strengthen even more people having opportunities locally in their area to volunteer, etc., because we all know that's good for our health, it's good socially, and helps with some people's goals. So hopefully that is quite an overview. There's a lot to say, and we're very passionate about this area. There's always going to be a lot more to do, but we are proud of the base that we have got at the moment.
Right then, to move the recommendation is detailed in the report. I'll seek for a seconder.
I'll second that.
Thank you. And I am now going to open this floor for a debate. Cheers. Councillor Girling.
You're very surprised that you said my name.
Oh, no.
I think the report's great, and I'm really proud of what we do as a council, to be fair, in terms of our adult social care and health, and it's absolutely amazing. And as you said in your speaking, there's still lots more to do. We're not there yet, but we're going in the right direction in a strong way. What I'm particularly interested in is a third sector element to it, because you say networking of people in that is really important, and volunteers are key to that, because without the volunteers it all falls to pieces, and that's from everything, any sector in it. And what I've learned in what I've been doing within my community is it's the simple things often have the biggest impact, positive impact. But the worrying thing is, from somebody that organises something, is like I do during the winter we do a Sunday roast for pensioners, because the nasty Labour government got rid of the pension winter fuel allowance. I know they U-turned on it, but they got rid of it, and we get the volunteers there, but then I'll go to something else, and it's just, not the volunteers, the people attend. Then I go to somewhere else, it's the same people who attend that. Then I go somewhere else, and it's the same people who attend that. And what I'm always conscious of, because we have a capacity, our capacity is 80 meals, is the ones that go generally can afford to go, even because I do it free, because I want to make it so that if you can't afford to go, you can't afford to buy a meal, you can still go. The trouble is having access to those people, to be able to say to them, look, come for free. I do social media and I do all that, but it's getting that. Really, we would like help from you to say, actually, Keith, in your area, these people here are on our radar, and I know GDPR comes into it. There's got to be a way around it, because it's to the benefit of them. Yeah, these are in your area. Yeah, can you even get them to contact us, so we can say, yeah, come along. So we provide lifts and everything if they can't get there, and so that to me would make what we're doing a lot more complete, because we're reaching the ones that are unreachable sometimes. And I think if that's the element to what you do, I think is missing. And I know why, because you can't do that because, and but actually that would be really helpful. And I'm sure there's other organisations around the county that do that sort of thing, but it's the same people turn up every time, and actually there's some that would really benefit from coming. And some of the comments I've had from some of these pensioners, it's really heartwarming, transformed their life. They were isolated, didn't go anywhere. Now they've got friends and they meet up, and they go out and meet up and things like that. So that to me would be a real sort of good target to aim for, to be able to support the groups that are trying to do their best for the community. Thank you.
Thank you. All the people that run things in their local communities are so incredibly important, and those local leaders, local voluntary and community organisations that can raise volunteers in a way that is quite hard for a council to do are so important. And as a big anchor organisation, we always want to make sure that we're doing what we can to support voluntary community sector and community leaders to do what they do best. Your specific question about can we join that gap a little bit more? Yes, we absolutely can. And I think that's one of the things that we have been reflecting on. Certainly what we would like to do as we're strengthening what we're calling our neighbourhood teams, so joined up more of the statutory teams that are on the ground, making sure that relationship with local voluntary and community sector, local community leaders, other organisations that are on that geographical patch, how we can make sure that we can, because we can ask the person, would you like the opportunity to, can I introduce you to this thing that happens over there? We can absolutely do that. And I think from an adult social care perspective, we hugely welcome that and want to challenge ourselves to help with that connection. Absolutely. So yes, I think that's part of our direction.
Yeah, thanks for that, because that's really welcome comments, to be fair. And just in terms of the volunteers, and the benefit they get. Now the criteria to get your free meal is you have to be a pensioner. 20% of my volunteers would qualify to sit down and have the meal. Yeah, and they love it. One of them's in her late 80s who volunteers, and she will not sit down and have a meal until all the volunteers sit down and have a meal, and she's dishing them out and everything. So it's, I know what it does for me, and I could actually sit down and have my meal actually, but I think the volunteers might walk out if it did that. But it does. It's an amazing thing that the volunteers, it's really how you encourage. And you're right, it's easier for us to get volunteers. I've got 30 volunteers. So when we do a roster, because I don't want 30 volunteers turning up, and it's brilliant.
I mean, it's great to hear the enthusiasm for this, and we do want to encourage more of it. I think there's something for me that's quite important around the language that we use with people, because not everybody identifies with things in the same way or the way that we would speak them necessarily from a council perspective. So quite often attracting men into some of these services is really difficult, and actually, if you think about it, we have to look at what the things are. So we've had examples where we've had men's gardening clubs, really, which came from men who are grieving from things, but actually they want to do something, but they just don't know how to access it. And some of the biggest advocates of these things are the other men or the other people. So people who have stepped over the line and actually gone to the luncheon club or whatever it is that they're going to, the community group or whatever activity it is, getting them to talk to other people as well, because actually they are heard much better than we are, really. And so actually we can help facilitate some of those things and enable things to happen, but actually the impact of getting the results that you want are often done by other people that we can help to get to that point.
Councillor Gowland.
It's kind of a related question, maybe the other way, coming from the other direction. So you talked about the data, the research into trying to find evidence for what works and what doesn't, or what's most effective and what's least effective. And I just imagine that's a highly chaotic sort of piece of work, because really of the reasons you just talked about, you've got lots of people in lots of different situations, and some of the interventions are tiny and some of them are really profound. So really, I'm wondering how, without being difficult, how do we judge this? How do we judge whether this is working?
Thank you. That's a huge question. I think we have to be both long-term and pragmatic now. So I think the long-term stuff is actually we've got someone that is now going to look for some more specific partnerships with our universities, and we do lots with our universities, but some more specifically targeted grants that are more about adult social care, and get some of that investment. And we have actually got a piece of work that is about to go into its first phase, which is around falls, actually. So I think absolutely taking that long game approach to building a good evidence base is really important. But also there are lots of practical, good enough, not gold standard level of evaluation that you can do, which is around tracking groups of people that have had some crisis support around them, and actually what was the impact for them? Did it get in their own feedback? Did that help? What happened next to some of those people? But also where we're looking at, I'm going to use frailty again, actually, we've got a pilot happening, which is a collaboration between the hospitals and social care, and it's a hub where we're identifying people that might have had the first few difficult things happen, and then they come and get more intensive support and a holistic look by a multi-agency joined up team that will then put a number of things in. I've seen other councils that might do something that is, here are 6 interventions that interventions is such a horrible word, but it might be somebody that can accompany you to a local club. It might be a voluntary, it might be a volunteer. It might be here's some balance work or reablement work. So 6 things on a menu, because not everyone is going to need the same thing, but within a particular group of people, they were understanding someone that had had a first fall, for example, and giving them 2 out of the 6, and then just tracking who had a further fall, who what happened to those people against a control group. And I think I think we have a good amount of skill and learning to do good enough evaluation at the moment to be able to show, is this a model that's really working for people, or could we do it in a better way? So I think being pragmatic as well as some of the really good levels of evaluation in a longer term way are where we're going to go.
Just had a few comments to that. I mean, I think I absolutely agree with that, but I think prevention takes time. And actually, one of the things that we see is investment in prevention, then there becomes a dip in or a need for money to go elsewhere, then it comes away again. So that's why we never get that longitudinal look at whether the investment is working or not, really. So I think it's important that we stick with it and stick with it for some time, because actually the impact that we'll see is less people needing social care or needing health and social care in the longer term, or the quality of life. People may remember that years ago we used to do quality of life surveys with populations all over the country, and as soon as austerity hit, we stopped doing those things because people were upset with, you know, having services being cut away and stuff, so the quality of life felt that it wasn't any good. But we need to do some of those things in order to be able to understand what's working and what isn't working, really. And I think the other lesson I think for me is small amounts of money make a big difference, but actually if you overcomplicate those or you overprescribe what you need to get back from them, then actually it becomes less interesting for people to do it, or the right people to do it. And I think there's something about making sure that we trust in some of that process to enable us to get those outcomes that we want, because you'll see it pop up somewhere else, the impact that it's having, really.
I love the term good enough. That's but I just wondered, are they sort of gross numbers? Have we seen numbers of falls, things like that? Really simple, big numbers. They're reported. Okay, thanks.
Any more questions?
Just a very quick
Okay.
question, sorry.
All right.
I meant to ask it when I was doing my first bit. You mentioned, my ears pricked up when you mentioned the Thriving Communities programme, which I don't really know much about apart from what's in this report. So I'd like to know more about that, please. But he also said the word grant. So I'd like to know how to apply for the grant, please. Could you send me the information on that? Thank you.
Thank you. So Thriving Communities is you've got to call. Got to have a title for something if you're trying to promote it, haven't you? So it's the council's whole look at prevention. It's about the council saying prevention is one of our most important principles or way of organising what we're doing. So we're calling it Thriving Communities. It's about further engagement with our communities. We do have a range of voluntary and community sector grants. They are led by our police department and the public health team. So we've had a range of grants that have gone out in different ways. They're looking at the model of how easy and visible it is to see, and that process of applying for them. So I actually, there is a whole council working group that is starting at the end of today that I'm joining. So I will just take that question about visibility of where people see that they can apply to. You look like you were going to come in then, Gal.
Just that the local resilience fund is out now,
Yes.
so there are funds that are available now. That's just been relaunched.
Yes.
Yeah.
So the voluntary and community grants being in one place, and I think it is about moving away from perhaps departments having bits of grants and starting to make it visible in one place is really important for our voluntary and community sector. But also under the Thriving Communities programme, it's bringing together thinking across all of our contexts, children's, adults, all age, thinking about area teams, thinking about what localities and neighbourhoods need to look like in terms of the way that we organise our own teams together. aligning with our health family partners and other organisations, and looking at a range of those very early supports, like those coordinator roles, what they're doing, looking at all of that in one place. So that's what the Thriving Communities programme is doing. What we've asked into that is there are some groups on the edge of adult social care that I described earlier, or that may be drawing on care and support that we think more people have got a goal to get into work and volunteering, for example. What can happen at that community level to get some more opportunities, plug into more local businesses, etc., to do that. So it's a whole wraparound, whole council look at very early prevention.
Has anyone more questions? No? Okay. I'll ask a question myself then, if I don't mind. Well, it's an excellent that CQC rated as prevention offers a good that flagged a gap regarding unpaid carers needing more support to maintain their own well-being. How is the all-age careers strategy behind the structural reforms right now to direct closely this gap, ensuring carers aren't reaching breaking point?
We care passionately about unpaid carers. So I know we have been here before talking about carers. So unpaid carers are family members or friends that are doing a level of support for somebody. Lots of us in this room will be unpaid carers. Making sure that we really help people to understand if they are a carer, working with all the employers across Nottinghamshire to understand that they'll have carers in their workforce and they may need a bit of flexibility to go and take dad to an appointment, etc., is really important. So we've got a whole strategy that was co-produced, co-designed with unpaid carers, and we've got some good progress against that, but we've got a lot of work to do as well. Our last census in 2021 showed that there were about 82,000 self-identified carers. There'll be a lot more than that. Not all carers will want or need to have support from the council. There'll be some people that have got a whole family supporting somebody and won't necessarily want or need the council. But that we know that we've got a lot of carers that are either at the start of that caring journey that just really need some good information and advice, or connecting with other people that can give them little tips and things that you know, when somebody mentions something to you and you think, oh gosh, I wouldn't have known how obvious that was or how useful that was if someone hadn't have told me. So those connections and early information being really important. But then we also know that we have a lot of carers that are caring for their loved ones for over 50 hours a week. And some of that's going really well, and some of those carers are really struggling with their own health and well-being, and they're tired, and it's really hard to even leave the house and have a haircut, for example. So making sure that we are offering good information and advice, we are offering an assessment, in a think family way, for those carers is really important. We know we've got some work to do because we've got some carers that are waiting for an assessment, and we've been prioritising looking at that. That's one of our areas that we're trying to improve. It's also good that we've got lots of people identified and coming to us for those assessments, but we need to do more to make sure they're not waiting for very long. We have contracts with a range of providers, including the Carers Association, who provide a lot of care and support. We've got lots of bespoke groups. For example, if you're a carer for a veteran, for example, so very targeted small groups that we can link people to. And we also have the ability to give people a short break. That means we can put some care in to support their loved one, or they can come for an overnight stay so that the carer can have a break. And we have some small grants, because often if you're caring for over 50 hours a week, it means you're not able to work. And that can often mean that when those carers get a break, they haven't got enough money to do something for themselves. So we've been attracting some free gym memberships, opportunities to go and do something for your own health, mental health or physical health. So we do a whole range of things. It's a massively important area for us. We've got a lot more work to do, but I think we're quite clear on what we're doing well, what our next steps are in that strategy. We want to have more carers that come and work with us and give us their feedback. We also understand that carers don't have a lot of time often to do that. So being able to have carers that work with us in a long-term way can be hard. We also know that nationally, through all of the CQC assessments, carers is a theme that's come out really strongly, that is going to be a focus nationally. And going forwards, I think there'll be some, we know that there'll be themed deep dives from CQC on carers, because it's really important.
Right then. To ask Martin to read out any areas for further consideration that has arose from this discussion.
I think from listening to what members have said, I think it would be helpful if at some point in the future, if like some further information on the work that's been doing to like link with like CVS would be like really useful to kind of like, obviously that's what Councillor Girling was keen on. I think obviously you talk about you want to develop that more, so I think that'd be interesting if we could just have a short written briefing for members on that. Just note about thriving communities, it did actually come to overview in January, so I'll recirculate that report. That's obviously, that was 6 months ago, so I think it would be useful if we could request a written update from public health colleagues on just where like the thriving communities project is. It was in quite its early days back in January, and also to note that there was a commitment at that meeting to involve members in very specific parts of the development of that activity, like during like just doing like very short task and finish reviews on a very specific part of that work. So I'll talk to public health colleagues about that as well.
And then to note, the recommendations have been moved and seconded to take vote on a show of hands. Thank you. Right, I'm going to agenda 9, work programme. This item will be introduced by Martin Elliott.
Yeah, the work programme, obviously this is the last meeting on the current work programme, the 25-26 one. So members will be aware we've got the meeting starting at 2 o'clock this afternoon. It's a hybrid meeting, so it'll either be it's in one of the meeting rooms here, I can't remember which one, or online. And we'll get some information from Guy and colleagues about the big priorities coming up for the department over the next year. So members can then make suggestions for which items they'd like to consider for inclusion on the work programme.
I'd like to close the meeting. Thank you.
Thank you, Chairman.